Hello, everyone. It's Dr. Jensen from Dean's Chat. If you're on the fence as to whether you want to join the American Podiatric Medical Association, jump on in. It's a new APMA. Whether it's advocacy concerns, scope of practice, billing and coding, consider membership at the APMA as your professional insurance. Hello, everyone. Welcome back to Dean's Chat, where we discuss all things podiatric medicine. My name is Dr. Jeffrey Jensen. I'm the Dean at the Arizona College of Podiatric Medicine and the co-host for the Dean's Chat podcast. Once again, I'm with my co-host, Dr. Joanna Richey. Hi, Joe.
Hey, Jeff. How you doing?
I am doing great. I'm fresh off a little vacation in Florida.
That's right. You had some tournaments. How did it all go up for you?
You know what? It's like golf. Some days you're great. Some days you're not so great, but it was really worthwhile and fun. So I'm glad to be back in Arizona.
And that's what makes it fun, right? Is that journey of deliberate practice and getting the chance to go out there and just see how it goes.
I need to exercise a stronger mental game.
All right.
You know, because one of my friends was saying shooting is like a flat pond. If everything's perfect, there's no ripples. But as things start to go bad, the ripples start to multiply. And that's when you got to have better mental game. I thought that was a great analogy.
That is a good analogy. You can use that in so many places in life. Because I think
Totally.
I probably need to work on my mental game a bit more too.
Yeah, when those ripples turn into waves, that's when we get challenged.
Right.
Joe, we have a phenomenal guest, repeat guest, no stranger to Dean's Chat. I want to welcome back Dr. Dyane Tower. We're on first name basis already. Dyane, welcome back to Dean's Chat.
Thank you so much, Jeff and Joe. Great to be back.
You know, last time when we were having our interview, we went on a bunch of tangents academically, and we never went back to the origin of how you found out about podiatric medicine. So I think today we've got we're going to go back to that laundry list of things we didn't get to. So if it's all right with you, let's kick it off with that. How'd you find out about podiatry, Dyane?
Yeah, let's kick it off with that. It's funny that you mentioned golf because that's how I got started into podiatry. I played golf in college and I worked a lot with our orthopedic surgeon. He was the team doc for our team. And I shadowed him and worked for him. He was a spine surgeon and didn't like doing feet. It was a rural place, not a lot of other providers in the area. So he was general orthopedics with a specialty in spine. And when I worked with him, he was talking about feet and how much he didn't like working on them. So we saw a lot of patients, did a lot of hammer toes, a lot of Achilles tendon surgeries, and he introduced me to podiatry. And it was through his work, and he set me up with a podiatrist that was nearby, but not in our little town. And that's how I learned about podiatry.
Oh my gosh. I love that, actually. So where was this location-wise?
Northeast Missouri, in Kirksville, Missouri.
Okay, very good. And so that led you quickly or not quickly into applying to podiatry school, and you went to Scholl College in Chicago.
I did, yeah. It led me to apply very quickly. I graduated college in 3 years and went straight on to podiatry school, and just families in St. Louis. So Chicago was a close place with great reputation, great alumni network. And that's where I spent 4 years going to school before I went to North Coloroado Medical Center, which I know we talked about that last time, Jeff, where I met you during residency. So,
you know, we don't mind doing some shameless plugs on Dean's Chat. I mean, that's all good. You know, I remember you as a student, Dyane, coming through as a clerk or extern. That, you know, terminology is different in different areas of the country. But I remember with Dr. Hatch, Dr. Davis, Dr. Casvin, Dr. Giacola, we're all thinking, how are we going to get Dyane to come to our residency program?
I'm so glad.
Oh, it worked out great, didn't it?
It was fantastic.
All right. Sounds good. So from there, I think, Joe, maybe we should switch into some of the data analytics and different things we were chatting about before the podcast.
Yeah, because we touched a little bit into the research area, but not enough to do it justice that I think it would definitely, I know I have a couple things that I'd love to follow up with her on from the last time. So let's do it. Let's dive into research.
Yeah.
Am I going first or are you going first?
Oh, you can go first. That's fine.
Actually, go ahead, Dyane. What were you going to say?
Well, I was just going to say, I got my start thinking about a lot of this data analytics, and especially in the quality improvement area. Jeff, you remember our resident clinic up at Sunrise in Greeley, Colorado. And we had a wait time of 8 months, I think, to see us as the podiatry resident clinic there. And that's really where a lot of this started for my interest in quality improvement. And right now, a lot of the work that we're doing is demonstrating the value of podiatry and the work that we do to for patients with diabetes, patients with PAD, people who have or need surgery. And it's really that start in Colorado. So when I was doing my MPH program, we had capstone projects, and it was that I went back to Colorado and studied that site to try to understand the flow of patients and the referral patterns so that we could improve the wait time. So people weren't waiting 8 to 9 months for something that was maybe more on the urgent side, not just routine care or a screening. And that's really where I got my start for that.
Wow, that was a springboard for a career.
Yeah. Looking back, it was.
So what did you find early in the day? I mean, I remember we had this resident-run clinic, and the residents were, and if the surgery needed to occur, you did it at North Colorado with Dr. Hatch or somebody. But what are the origins? I mean, it always blows my mind when people say, "Oh yeah, we have an 8-month wait." It's almost like being in the NHS in England or something.
Right, and what we were finding was the different conditions that were part of the wait list. There were people who had more routine needs, more urgent needs, or something in the middle. And we were finding that all of those people were pretty much just in line based on when their referral got put through. And so we started looking at it more based on that level of urgency. So it was urgent, emergent, or routine, and started tracking things a little bit differently so that if something was urgent or emergent, they would jump the list over someone who needed a screening or an annual wellness appointment so that we could understand how to avoid bigger problems with those people who are having urgent or emergent problems rather than just waiting on the same list as somebody who needed a diabetic foot screening annually, and then somebody who had a paronychia and needed something more immediate to happen.
That makes sense. Joe, your thoughts?
Oh man, this is the stuff I also find incredibly interesting, right? You identified this problem when you were a resident. Problem, issue, quality, whatever you want to call it, right? There was something that you're like, I think that we could do this better. How did you take that moment of like, I'm curious about this, I think we could make it better, and translate that then into something like a capstone project, and then figure out how to develop a way to measure and maybe not predict, but analyze data in a way that actually is impactful to evoke positive change?
Yeah. Well, I think curiosity is a big part of it. And that's something that I'm very curious about, how things work, where we can make changes, where we can improve. And so as I was there, I certainly felt the frustrations, not only of patients, but also the administration at the facility, trying to understand how to get these patients in who need something more urgently so that they don't have to wait 8 months for their ingrown toenail procedure for something that's red hot and swollen right now. So certainly feeling that frustration while I was there, but not necessarily knowing or being equipped to do the analysis or figure it out. It was when I was then at the MPH program at Dartmouth, going through that, we had a whole session of courses on quality improvement where we learned how to use statistical processing control charts and all kinds of neat tools in Excel and other programs where you can track those items. How long is it taking for a wait for this, and this over a period of time, where you would then be alerted by the chart to say, "Oh, this one's out of place." Do a root cause analysis to try to understand it. And so it was in those moments in the classroom, learning about those things. And this is why it was so great that I had gone through residency when I did that program, because I had a lot of experience to draw upon for projects and just thinking through how the real world works, that you start thinking, well, what made me frustrated in that situation? And is there something that we can study there to try to improve it for the next round of residents, the next administration of that facility, and certainly the patients who are there who need that kind of care?
Oh, I love that. Yeah. And so
all together now.
Sorry, Jeff, I have another follow-up on that, because I think this is also where, like, especially right now in medicine, there is such an opportunity and a real need to figure some of these big variables out that also really demonstrate the value that we bring to the hospital system or the payer system or to our patients in the value of what a podiatrist is and does. Can you talk a little bit about your experiences in the changes you've seen over the last 6 to 9 months, either in the kinds of work or the kinds of questions, or how is that starting to translate into some of the new projects that have been coming out?
Yeah, you all probably have seen over the years, there's articles that come out from other specialties where they may compare their outcomes to podiatry outcomes, whether that's cost or length of stay or complications. And so that's one of the areas that we're focusing a lot in the work that we're doing right now, is demonstrating the value. And that could be financial value, cost effectiveness, that could be cost savings for a hospital system, but also on the outcomes perspective. We have a project that's being presented, or was recently presented at a national meeting for public health. And that one in particular looks at adding a podiatrist to vascular surgery, care by a vascular surgeon, and that in patients with diabetes and or PAD, so vascular surgery providers seeing those patients, when you add a podiatrist onto that care team, the odds of major amputation are statistically significantly reduced. So
wow.
People, vascular surgeons are doing major amputations. Of course, we're not. So it makes sense that the risk is high. If somebody goes to a vascular surgeon, they're likely to get a major amputation because that may be what they need. But when you add podiatrists onto that care team, the odds are statistically significantly reduced of that major amputation. And you all experience it in your practice, and they may not try a toe amputation. They may not try a TMA, even though the vascular studies may tell us in the end that person may end up with a major amputation. But sometimes it's worth the try, especially if the patient wants to, and they're really interested in giving it their all, and they really want to try to save their leg. So I mean, that's a perfect example of something that when it's published, podiatrists will be able to go to their facility and say, look, this is why you should hire me. This is why you should have podiatrists on staff. This is why we should have a multidisciplinary team to care for our diabetes and PAD patients. And this is why it's so important.
Oh man, I love that. Jeff, I'm going to throw the ball back to you. Otherwise, I'll keep asking more questions.
Well, that's okay. It's interesting because technology is evolving in terms of data analytics, but technology is also evolving in terms of care. So to your point, Dyane, and not that long ago, in many areas of the country, a below-the-knee amputation was the go-to procedure. But now, I mean, reperfusion of the foot is so commonplace in so many different areas. You'll remember Dr. Hammond, our vascular surgeon at Rose. Everybody was doing fem pops 25 years ago, and she called them a head of steam bypass. and it wasn't helping anybody, right? So you can see that mindset. But I think what at the same time when you and I said, I love that, Joe, I was thinking about that patient experience is so important. Yeah. And when you put together two things you talked about, one was pain points and the second was curiosity. And if you encapsulate that in the patient experience, we're starting to deliver the things that the patient needs in terms of time to care, accessibility to the appropriate treatments, and then having research to back it up. I mean, all of this is kind of coming together at a really important time, especially in light of, 5 years ago, that article came out in Diabetes Care, where we're seeing increase in amputations at the digital level, the foot level, the below the knee level. And now I get the sense things are shifting around and we're meeting the patient's needs. And to your point, I just loved your statement about curiosity and pain points. And I was thinking about pain points. Is whose pain point, right? It's not the administrators at the hospital. It's the patient's pain point. And if we can solve those, or at least delve into them with a little bit of curiosity, then you start to see progress. So kudos. That I'm curious about some of the other some of the other potential publications and things you're working on. Sorry, Joe, I got on a little rant there.
No, that's okay. But like, I want to piggyback on that because there are pain points for the administration. They look very different than they do for the patient, but they absolutely have their own set, right? You have a patient, they come in to the ER with a diabetic foot ulcer, they go get discharged, then they come back again, they get admitted, they get discharged, they come back again, or they had a surgery and they come back with a complication. They want that streamlined patient care. They may be looking at it through a different lens, but this is where, again, there's such a huge opportunity to bring people together. And not only is it the right thing to do, right? Like that should be the real core focus of it, but it also is the right thing to do for the responsible parties of the system that are going to be paying for, or the ones that are going to be leveraging it. So there is so much opportunity. We all know the value that we bring because we see it daily in the patients' lives that we impact. Our patients know it, but helping the rest of the community see that. And Dyane, I loved your point about the vascular surgeon. My four favorite people in the hospital were my vascular surgeon, my plastic surgeon, my infectious disease doctor, and then my internal medicine doctor, right? Like those were by far the people that were constantly on speed dial, group texts, keeping everyone on that same team page of, what's happening today? What does the patient need? What does the discharge plan look like? Do we need a wound vac? Do they need PT clearance? Like whatever those check marks are in the system. Having that coordinated care is, again, why those patients leave the hospital with the highest likelihood of success. And so I really appreciate that the APMA has taken on this initiative to back this up, the things that we all know because we live them and we experience them. But it matters to back that lived experience up with the data, with the evidence to say, hey, you asked, or maybe you didn't ask, but here it is. I remember last time we talked about someone else defining your value for you. This is that opportunity for us to be able to not just say what our value is, but really back it up with evidence to support it. And I'm curious, in some of the areas that you've seen, where is there the most opportunity in the space for some of this research?
Well, one of the things that you mentioned or alluded to here is the audience. And I think that plays a key role into this. And it's knowing who your audience is, because for so many projects, even one project, the project we were just talking about, add a podiatrist to the vascular surgeon and the odds go down. The audience matters in the sense that if you're going to your administration to talk about it, you might be talking about dollars and cents, building a team, what they might want to invest in to help take care of the patients. Their audience that they're likely focused on is not only their board or the financial aspects, but also the patients and the constituents they serve who are, providing ratings of their hospital or going to a different hospital if they're not happy. And so it's really, or advocacy, that's a really big part of what we're focused on, is providing the data to drive our positions related to our advocacy efforts. And so, that's a different audience. That's an audience where you mentioned lived experiences of patients. Those are vital to our conversations with our legislation bodies. And that's really where the lived experiences come in. But those stories and those anecdotes have only gotten us so far in those conversations. You can share all day long that this happened to this patient, and that's impactful. But at the same time, the data does help support that position. And that's really what we're going for with the work that we're doing right now, looking at patients who have certain conditions and their treatments that we're providing and our outcomes to demonstrate that the care that we're providing is important to keep people moving longer, to keep their quality of life higher, to keep them as contributing members of society for as long as possible, because that's how we make the world go round.
Yeah. I like that. That's like the student recruitment slogan, podiatrists move the world. There's a lot to be said there.
Yeah.
I think that's fabulous, Dyane. Joe, you want to piggyback on that?
We can shift it a little bit if we want to go into some of the changes. So when we start talking about research and evidence, in ways that it helps to demonstrate that value, bring different parties together. Also, the advocacy part, which I hadn't even really. So again, the more you start thinking about all of the different places where this data really does matter, and in a world where now data runs everything, right? We have so much data, we don't even know what to do with it. How do you package that in such a way to present it for something like journals? And we can transition at some point into something like, I know there's some changes recently with JAPMA, but what does this look like then when you start thinking about publishing this data and making it publicly available?
Yeah, I think it's key in that first process, even of coming up with the project of, what the topic is globally, if it's a certain condition, certain surgery, certain patient population that you're interested in, and really focusing on what is the story that we're trying to tell. And for the project that we were talking about, the story that group of authors wanted to tell was when you add podiatry, the outcomes are better, the costs go down, so we look at a number of different outcomes related to care of those patients. What's the length of stay? What's the complication rate? What are the major and minor amputation ratios? What does that look like? Who's the audience? So if we're going to publish in a diabetes journal or JAPMA, for example, our audience might be a little bit different. So we might focus the same project, the same outcomes a little bit differently in the introduction or the discussion to tailor it to who the audience might be. And then that separate audience of legislators, let's say, if we're talking about going to the Hill and, sharing what this research shows and why it's so important that podiatrists are considered physicians, let's say in Medicaid. Here's an example as to why, and that data will really help us support those efforts. So, and then of course, hospital administration, another different audience. So I think it's really knowing what you're interested in, maybe seeing overall. Does adding podiatrists to this care help, and in what way? And just doing different iterations of the analysis until you understand what it looks like, and then telling a story around that. And that's where the patient experience also helps, because we all have stories, I'm sure, of good patient outcomes and not as good, or outcomes that we maybe had hoped had been better, and go back to that root cause analysis and look and see what happened during this process for this patient that could have been better. And is there a pain point there that we can look at more globally to try to tell that story?
Did you know APMA provides help with public health initiatives such as fall prevention, opioid abuse prevention, and addressing health disparities?
Did you know the APMA provides over $400,000 in scholarships annually to students pursuing podiatric medicine, helping the next generation of foot and ankle specialists?
If you're serious about this profession, if you want to grow, to lead, to make a lasting impact, join APMA today.
So I had two questions, Dyane. The first one is, have you gone down any rabbit holes? Because when we're doing research, we always have a question, and sometimes you get off on the wrong tangent and you'd say, okay, we got to start over. Have you experienced that at all?
Oh, yes. This project that I'm talking about, I know it so well because we've been doing analysis on it for over a year, trying to pinpoint the population, making sure that the population that we have in our data set is the population that we're the most interested in. So, oh my gosh, yes, absolutely. Almost any project, you get on those tangents, and just like our conversation, it's like, oh, that made me think of 3 other things that I need to look at and make sure. And then you find that, you say, oh, that's another project right there. That's something I need to come back to and do another project on, which is where we've landed with a number of these, just looking at different patient populations, people who have ankle arthritis and falls prevention, people who have diabetes, PAD, and amputations. There's just so many topics out there that are hot topics in our profession and our field right now.
Yeah, Joe, it reminds me of our student-initiated research proposals the students bring to us, and then we, among the faculty, we work on them, and what it looks like at the end of the day does not resemble the initial program. So that's so and I think it's important to acknowledge that, right? First ideas are just kind of, you throw them on the table, throw it against the wall, vet it out. Maybe there's some better contributions we can make to the literature for patients and providers alike. Second question I had is the role of industry in advocacy. Because there's no shortage of tremendous technologies, products, whether it's surgical, wound care, you name it. And a lot of these companies are spending a lot of money on the research, and they're spending a lot of money on the patient outcomes, and also for the healthcare system as a whole. What is the role of industry when we're starting to talk about an APMA level deep dive into what's best for our patients?
Yeah, it's a really good question because, at times when we see literature, especially early on in a product's life cycle, or not even just a product, but like an idea, right? A lot of the research that's out there is industry supported. And I think that's one of the areas of a paper that people should pay a little bit of attention to, is that area where it talks about where funding maybe came from. And it's not that it's all bad. I'm not saying that it's bad and that a project was supported by a company. It's just something to keep in mind when you read the results and you take your own personal takeaways from it. For the work that we're doing, we've not gotten any grant support for the research that we've been doing so far. And then on our advocacy side, we don't necessarily have grant support for any of that work. There's certainly entities that may have similar positions to APMA or align very closely on things that APMA is doing. And that's always helpful because then you go to the Hill with a joint message and being able to have and show that not just members or podiatrists are supportive of this, but other people in other industries are also supportive. And again, it all comes back down to the patient and the patient experience and the patient outcomes, because that's really what we're all working toward and working for every day. So there's certainly times when things align, but there's times when you can maybe tell that something was industry supported just by the tone of the paper or information that's provided. It may seem very commercial at times.
I asked because I've worked with Marsh and Nussgaard a lot. There's a wound care consortium, and a lot of companies are involved, and they're very influential in CMS decisions. Yeah. And so we're starting to, it gets blurry sometimes. And Joe, it's no different than the CME issues we talk about, industry sponsored or not. There's some value everywhere. You gotta peel it out and figure it out. And to do it the best you can for everybody involved. And just there's that line, and it's kind of blurry, is my point.
Yeah, and that's also for the learner or otherwise person, reader of an article or something, to at least know that information and take that and use it for their own personal decision making as they decide what they read, what they saw, whether that is in alignment.
Yeah. Whenever we talk about these kind of things, I go back to the origins of the wound vac, right? It was bed technology and negative pressure. And when it first came out, everybody thought, oh, here's a technology looking for an indication, right? And look at what a significant difference it's made in patients' lives over the last 30 years. And if it wasn't for industry and their documentation and pushing it forward, it could have died on the vine, like a lot of different technologies.
Yeah. Yeah, you're absolutely right. It's that R&D process where they go through iterations, just like a research project, and come up with something. And, at a certain point in time, there may be steps that can be, going for grant support to study it so that it's an unbiased project, and, seeing how all that pans out so that there can be some literature out there that stands alone, unbiased, without any question of, well, did the company have some input into this process that could have biased it unintentionally? There's always that possibility.
Now I'm starting to think about more projects. Remember topical oxygen when it first came out? The running joke was, until wounds have lungs, topical oxygen isn't player, right? But we've seen all the research come out supporting it now. So, I mean, I just, you know, I just have to look at everything with a keen eye and parse it out appropriately. But I mean, my point is everybody's got a vested interest in patient care, and then you just have to kind of sort out the objectivity sometimes.
Healthy skepticism.
I like that. I think that's the words I was looking for. Joe, your thoughts?
Oh, this is always a fun topic. And it's funny. I joke that I'm a skeptical optimist because I am genuinely the silver linings person, but I always have to have, and I think your point, Dyane, of transparency is really where we kind of level that playing field. Just because a study has funding from like whatever industry sponsor, there is obviously a layer of bias there. Like it is impossible for us to refute that. However, it doesn't mean that the findings of that study are completely invalid then. So I like what you said about it's really then up to that learner to have that moment of curiosity to then say, are the things that this research study is proposing, do these make sense to me? Do these align with principles that I already know, that I can use this information and apply it in a way that is going to make my outcomes better, help my patients in some way, help myself in some way? Like, what is it that I can take from this that can bring value, or that I can take my own study, or I can take and I don't know about this because of X, Y, or Z. Let me see if I can build upon that. And that, I think, is really what moves the needle. And Jeff, when you were talking about things like the wound vac, I mean, there's so many different technologies that I think we hear about these new, it could be an implant device, right? It could be anything. You hear about them. And there are those moments where you're like, that actually makes a lot of sense. Or, I don't know about that, right? Like, and it doesn't mean that it's wrong. It just means that gut check moment of like, I'm not sure that this aligns with the principles that I know. So I might take a little caution on that. And I think that healthy skepticism, again, when you are the one that's going to hold that ownership and responsibility for the outcome for your patient, we owe them that skepticism to take that expertise and use it in a way that helps vet this information. Because just because it's new doesn't mean it's bad, but it also doesn't mean that it should be trusted. So like, how do we start to bridge all of those gaps? And that is the thing to me that's the most exciting about research, is that is how we start to figure those things out. And without doing really good research, we don't get to answer those questions. And I think we've seen lots of different places in technology that things that kind of came out and everyone was like, I don't know about this. And now we're starting to see, you know what, actually a lot of this stuff does make sense. There is some good principles behind it. There is some legs behind it. And we've watched things fail where we're like, yep, nope, that was a bad product. And yep, not a product anymore, right? Like, this is how we help define that. And that is why publishing your research unbiasedly, good or bad research, but like outcomes, you may not be the outcome you expected, but being transparent about that, that's what matters the most. What are your thoughts?
I think that last part there is so important, that if you have a project that doesn't turn out the way you thought, it's still really important to get that information out there, because someone else might try it and realize the same thing. And that can be helpful for everyone to know. But I think at times it's if a project didn't work out how you thought it would, or it's not statistically significantly different, people may hesitate and say, well, then this isn't important enough to publish. And I think it's still really important to publish those things, because showing that there's not a statistically significant difference in something is important and probably worthy of publication. So that's how we all learn. And that's how we all read articles and say, ooh, I like that. What if I did it in this population? And that's where we've come to some of the projects that we've done, is other literature has been published and we say, well, that may be true in the data that they're looking at, but we have a much more comprehensive data set. So let's look at it more broadly and see if that still holds true. Yeah. And in a lot of cases, what we found is that there are no statistically significant differences in the outcomes, let's say podiatrists compared to other people, other providers who do ankle surgery, let's say. There's publications out there saying we have statistically significantly longer length of stay or cost or infection rate. But we're publishing a paper that says there is no difference. And that just because we didn't say or couldn't find that podiatrists were statistically better or had better outcomes, the fact that we're no different is also very powerful, especially in that story when we're talking about the advocacy perspective, because now we can go to Capitol Hill and say, podiatrists are physicians. Look, no statistical difference between us and other providers in the care of these patients.
Well said. Also, if you publish data that isn't always positive, if somebody else is doing research, I think this is kind of piggybacking on what you said, Dyane. If you do a literature review, it helps define the gap analysis for what future research. So that's important. Yeah. This might be a good segue, Joe, into changes at JAPMA.
Yeah, let's do it.
All right. Significant changes, open access to JAPMA. Dyane, do you mind spending a few minutes talking about the origin of coming up with that and then the processes of making it happen?
Sure. Yeah, so JAPMA has been around since 1907. It's had a number of different titles over those years, back from when it was the pedic items coming out of a group out of New York of chiropodists back in the early 1900s. Fascinating history. We can probably share some links to some of the old archives of the original journals. Really need to go on a deep dive. Since we're talking about deep dives, I did that. I looked at all of the old journals as we were going through this process. But we've been a subscription model for many years. So as APMA members would get subscriptions, so APMA members get access to it. But let's say somebody across the globe or in a different profession is doing research and they're doing their lit review and they notice there's an article or some in JAPMA that they would want to include in their paper and cite them. They would either have to pay a subscription fee or they could pay a pay-per-view article, a charge just for that article. And what we're finding over the years is that our impact factor, so this is a number that is assigned to journals and it's based on how impactful your journal is in the space that you're in. So we're, foot and ankle medicine and surgery, those kinds of spaces. We'd be compared to other journals in the space like Journal of Foot and Ankle Surgery, Foot and Ankle International, Clinics and Podiatric Surgery, Medicine and Surgery. And we would be compared to some of these other journals based on our impact factor. And it's not to say that's the end all be all of it, but it's a number. It's a quick comparison of things. So subscription model, people were limited to accessing it if they had a subscription or paid the fee per article. Now with open access, that means the articles are free to everyone to read so that all of the JAPMA articles that have ever been published are now open and available to anyone. So people who are doing research on any topic that there's a JAPMA article, they no longer have to pay or have that financial burden of the subscription or the per article charge to gain access to those, to learn all of the great work that's published in JAPMA that they can use to bolster their project in their lit review or understanding the gaps in the literature so that they can come up with their projects. Now, when a journal goes open access, there needs to be funding some way. And that typically is funded through what are called article processing charges or APCs. And that's where when you submit to JAPMA, you go through the peer-reviewed process. Once and if your paper is accepted, you would be charged as an author. You would be charged the article processing charge. And that's how the funding works for an article. And so at first, many years ago, when I was learning about open access journals and submitting to some, and I thought, I did all of the work. Why am I having to pay for this? But I think of it as I, as the author, am paying this small fee in the grand scheme of things, relatively small fee to allow anyone in the globe to read my work and to use my work and to take this forward and develop a new project based on this, or to use this to understand their population and how they could do things for their own project. So those are the big changes that happened at JAPMA recently. So that just started in 2026. So we're getting ready to put out our first issue with our new publishing partner, MDPI. And that's going to be through this open access model, and certainly encourage everyone to perform your research, submit it to JAPMA, and be a peer reviewer for any articles that you would like to peer review.
That's interesting. How do they get reviewers? I'm not familiar with that. I mean, do you volunteer your time? Are you on an editorial board? How exactly does that happen?
Yeah, we do have an editorial board that those folks serve as associate editors. So our editor, Dr. Warren Joseph, who you've had on Dean's Chat, live in person, I think even, he will assign the article based on topic, typically with an associate editor, and that associate editor will reach out and ask people to peer review. So if I have an interest in quality improvement, they have an article in that area, they could reach out to me and say, would you like to be a peer reviewer? And so we have, over the years, we have a bank of nearly 2,000 people who have peer reviewed journal articles for JAPMA. And so that's the primary group of people that we reach out to. But in our partnership with MDPI, they have an even larger, a much, much larger pool of peer reviewers with expertise areas all across the world and all across the different types of articles that we might have submitted to JAPMA. So, and there's certainly opportunity for anyone to get involved. So if there's folks out there listening who want to become a peer reviewer for JAPMA, we can make sure to get that information out too.
Yeah. Peer reviewers are kind of unsung heroes, aren't they?
Yes.
And Joe, your thoughts?
Well, and it's hard because, so I serve on the editorial board for a different journal, and what gets really challenging is to have a good peer review, you need at least two people, ideally more than two, but at least two people to go through the article and truly vet the sources, look at the statistical analysis, read the content of the paper, and be able to look at it very holistically. And all the things that we were talking about, right? What is the value that this paper can provide? Not to like rip it to shreds, but like if something's not quite there, you get the opportunity to send it back and be like, can you tell me how you came up with this? Or did, maybe have a statistician look at it, or whatever the feedback is, to allow the other party. It may just be something simple that they didn't think was relevant for some reason, but it allows this opportunity to kind of go back and forth. And having more than one person do this really allows it to be, you're trying at least to reduce the amount of bias, right? Because my one opinion about somebody else's work maybe isn't as useful as we have three people and two of the three both had these same pieces of feedback. That's very valuable to the person writing the article. And having been someone that's submitted my own research, the peer review process can feel very antagonistic, right? Like you get very defensive sometimes. And that really, now that I've sat on the other side of it, it actually helps me be a better writer as well. Like when you receive this feedback, like, okay, I can appreciate what they're saying here. And you just, go back and forth with each other about, I want my paper to be as strong as possible. And they want the same thing. So how do we work together to really try to refine this or polish it in a way that gives the best result? Because sometimes the feedback it's just not where it needs to be. And so it allows the author then the chance to go back and make it better. Or sometimes the feedback is something simple of this one section needs to be fine-tuned a little bit. And it gives them the chance, again, to make their work stronger. And having seen the revisions that people will come back with, it is such a rewarding process to be involved with, because you get to see somebody take something that, maybe they thought was really well refined, but it just wasn't quite where it needed to be. And you see those edges get polished up. and then get presented to the world. And it is a time consuming thing, but it is a very rewarding thing. And the more people that are willing to invest the time, the less burden it puts on everyone. Because what sometimes happens, and Dyane, I'd love your feedback on this. It's like the same people over and over are doing this work, and it just becomes fatiguing. And sometimes someone new will come in and it's like, oh, that was really great feedback that reviewer gave to this person. I'm curious what your thoughts are in terms of recruiting people and how that experience goes.
Yeah, it can be tough because a good review can take hours. Like you said, you're looking at references and making sure that the claims that somebody's using a reference to support a sentence in their paper, that's actually what the paper that they're referencing came to the conclusion of. Between that and understanding the statistical side of things and, weighing in on a journal has an aim and a scope of what the topics are that they may have. And they're really thinking about the audience. So back to the audience, they're really thinking about who's the audience of this journal, and does the content in this manuscript line up with who our audience is. And that's another piece of advice I would have if people are doing research, is making sure that as you're writing, that you have an idea of which journal you're going to submit to, because your audience is going to be, the key to how you frame those different paragraphs or the different sections of your paper. And so it's a time consuming thing though. And so, to your question about, it's a challenge, and you're right. We get some of the same people who are engaged, and it's not to say that others don't want to be. It's just making sure that those are, people are coming top of mind and showing up in the search of, we're going to be reading about Evan's osteotomy, who's an expert in that, and making sure that it's not just the same person who does hindfoot surgery or something. Maybe there's somebody who's published on this elsewhere, and we can invite them to peer review, because it is time consuming, and it's an investment and a labor of love, especially for people who like doing research and like seeing what other people are working on.
Yeah, when I was doing a lot of NIH study section reviews, I liked their methods, because if I was responsible for 6 or 7 different NIH grants and reviewing them, we had primary, secondary, and tertiary reviewers. So you knew when you had your 2 as a primary reviewer, you had to dig in deep. The secondary and tertiary ones are just kind of adding to the mix. And I don't know if they do that the same. I'm not even sure, but I thought that was a good method.
Yeah, that sounds like a good one. I think typically now it's a lot of each individual reviewer reviews the paper from their own perspective, the whole paper from their own perspective. And you can tell in the different reviews, somebody might be much more interested in the public health side of a paper, and somebody else is clearly very into the statistical analysis. And so one might comment about content outside of the statistical analysis, and somebody else might focus solely on that area.
Dyane, what are we looking for with the open access? What are the outcomes and the parameters that we're trying to assess to determine whether we're successful or not over a 3 to 5 year period?
Yeah. So our number of submissions that we've had over the past several years has been around 400 submissions, and about 200 of those are accepted each year. So we're looking at number of submissions overall, number of acceptance. So we get a percentage of accepted papers overall. And then one of the other big areas that we're working on is the time between being accepted to the time that someone is published. And that is a multi-month period of time right now when we were subscription model. And so going open access, we are no longer really having to wait for an issue to come out. Under the subscription model, somebody might be accepted in, let's say, February, like now, but their paper may not get added to an issue until later 2026, maybe even into 2027. And so their research that maybe seemed very timely when they were accepted wouldn't necessarily see an issue and be published until that time. So now when something gets accepted, it will be available online right away. All of them will be available right away, and then they will eventually be put into an issue. But if we published a paper today, in the next couple of weeks, it would be online and available for everyone around the globe to see for free. And then eventually it would be put into an issue, but it will have been available during that whole time in between.
That in and of itself is worth the price of admission. Because I remember I was joking with Warren one day. I said, I got an article published in JAPMA and I forgot I wrote it. I'm just kidding a little bit, but because it can take a long time, right?
It can take a very long time. Times, Yes.
All right. Yes. Well, as we said, look at the time. It just flies, Dyane. And we could sit here and talk all day long. Joe, any last words before we tighten things up?
Just thank you so much for all of the work that you're doing. Your curiosity and genuine interest in lifting and supporting the profession, Dyane, it's really commendable. And we are just really excited to continue to see how the profession moves forward with the evidence to support where all the value is to all of the players in this medical sport that we call podiatry.
Thank you very much.
Yeah, Dyane, I echo Joe's sentiments. Thank you so much for joining us. Thank you for all you do for the profession. It's just incredible. I think you hit the nail on the head when you said you're curious, and that's been shown throughout your career. So appreciate all you do for our profession, and we'll get you on a part 3 down the road on Dean's Chat.
Sounds good.
And we'll send you another cup.
Thank you.
All right, sounds good. Well, thanks again, Dyane. And to all of our listeners out there, if you're listening on Apple or Spotify, please give us a 5-star rating, or even better yet, leave a comment or two. And if you're watching on YouTube, by all means, become a subscriber. Joe and I will continue to bring leaders in the podiatric profession. And Dyane, I'm not so sure anybody's given as much to the profession as you have in that advocacy and research and APMA levels. So keep up the great work.
Thank you so much.
All right. Bye-bye, everybody.